Another thing, to kind of update you guys, I spoke briefly with Paula yesterday, kind of getting some guidance on where should we be focusing um, some of our efforts, because to me there seems just to be a lot of moving pieces when it comes to collaborative care and implementing within the state. Um, and she sent a letter to email to me and to Kim Schuler that kind of summed up our meeting. And she said what we should be focusing on at this time, when I say we, this group, or if we need to do, maybe a subgroup that needs to kind of work these issues out. Uh, but she said we should be at this point be looking at how do we roll this out statewide, which encompasses more than just having the codes with with a price attached to that. And so she really focused on we need to look in training and training capacity when it rolls out statewide. Will we can we meet that demand if several physicians offices at once starts wanting to be on board? Looking at once they're trained technical assistance, because you'll always have to go back to make sure they're following the guidelines and the outline of collaborative care. And then not only the policy part, which I think to me that might be more of the simple part, just because there's states out there that have it. I've been looking at Washington State's state policy, and that looks, I, I like that one, and it seems like it could very easily fit within the state. Um, but their policy requires an attestation letter before providers can actually start providing that service and billing that service. So that would be something we would have to look at, and how do we implement that, and who would be kind of in charge of that. Uh, Most likely that would be more on the state side. But Paula said, we should start looking at that now, and especially since we're kind of year two in uh, uh, with UAMS with the grant. I am looking forward. Hopefully, we can expand this grant to two more providers under UAMS. I think that will be great for this grant, and give us some really good insight on on different practices and how to implement it in those. So that's kind of was Paula's overview on, as I said, either this meeting, with everyone in this group, or should we split into a smaller group to kind of start working out on these issues, and start laying the groundwork of how will this look when we start rolling it out statewide.
That makes sense. Hey, Kim.
Hey.
David was just giving us an update on what's going on over at the state, and just kind of like what your email from Paula was saying. He was just explaining how we need to start looking at policy like training, TA assistance, and that kind of stuff as we look into turning on the codes, and just making sure we have a good foundation. So that he did review some of Washington's policies. On that, I don't know if are you familiar with Washington's, Kim? I know that we've been talking to a couple of different states on their approach.
Oh, um, and somewhat, yeah.
Okay, I just wanted to make sure that wasn't new information. And I don't want to mess up the grant part of that. Was it FFR, David, that was rejected? But we got some good feedback from our leadership at the.
Yes, yeah. So there was, a few mistakes on the FFR,
Okay,
but luckily our grant person, Mr. Ortiz on the SAMHSA side,
yeah.
did a very clear guide of how to fix it. It was, numbered one through, whatever. So it was a very clear guideline on how we need to fix it. And right now it's at our not our it's DHS's finance team, and so they're the ones responsible of correcting it and submitting it.
We can't hear you, Caitlin.
I said thank you. That's what
Oh, perfect.
I said.
Awesome. I just have to say, this is so exciting, David. So, one of the things that I hear you saying is that, we're starting to look at the expansion pieces outside of, um, the AHEX and the two pilot sites. Sorry, I apologize. I was late due to the
Oh,
technical
yes,
difficulty.
yeah, because I spoke briefly with Paula yesterday, and she, that's kind of what she was thinking is we need to start focusing on when this starts rolling out. Can we, laying down the foundation for, so we'll be able to handle rolling it out statewide with, multiple physician groups that may be wanting it at once, and how do we handle that and train it and provide the ongoing support for them.
Okay, awesome. One thing I just want to say, I think North Carolina is a great model. They've been doing a lot of work in this space, and um, I think they have 49 active clinics currently, but visited with them about their journey, and they've been on the CoCM journey for about 10 years. And so they're really a model on how did they get started, some technical assistance resources in addition to um, in addition to everything that we see on the AIM Center. And they're also going to be coming to speak at our conference in April. So I'm excited for them to come to Arkansas and be able to talk about that. Okay. Oh, sorry. My apologies. Here I am late to the meeting, and I'm looking to the next person to talk, and that next person might be me.
I'd like to say, David, we appreciate you stepping up there. We know it's been a lot of detail. There's so many details and grants, and then you've had to try to coordinate all these different entities of getting some things done. So it's good to see that we've been able to make some progress, and it's exciting to see next steps with Paula and with the state, because that is what's needed. And I think other states have had long journeys to get to that. And so I think you've got a great plan to have technical assistance is so needed. You can't just turn on the codes, but it is so needed. But it has been shown that if all the payers aren't paying the codes when practices begin to implement, so you might turn them on for the practices that are involved in a implementation process. So for example, like the practices that are already in the grant, like East Arkansas or UMS, since they are in it, you might look at some sort of a process where they can get paid because there's a lot of startup costs and practices. It's kind of a chicken and the egg that if they can't get paid, then their payer mix often includes 40 to 60% Medicaid in the state. So I think I appreciate what you're doing, and it just really does take a team moving this down the road. And so you've done a good job to get us to the next step. So appreciate that. Glad to help in any way that we can.
Yes, yeah, I will be relying on you guys for all the help and the assistance. Sometimes I get stuck in my office and then I forget, wait a minute, it's just not me. I have a wealth of people who are experts in this field that can help us get this going.
Oh, absolutely. Please know, David, we are here. We are excited and eager. Um, you've got the UAMS team, you've got the ABIN team, and we literally are just an email away. And if there's something that we don't know about, we've got some people that we've been working with across the country in different states that we can, ask them questions, lean on them. And so we are here and we want you to know we're excited um, and we're excited for this project. You know, one of the things that we talk about, and especially as we're talking to practices, is we're really changing the healthcare landscape, and that takes time. And so it's a culture shift. And, you know, we are into the end of the first quarter of year two. So we've really been spending a lot of time on laying a groundwork, developing resources, and now we're just starting to see change. And so I'll talk about that at my update. Um, when I say we're starting to see change, I am just so happy to report that Eastern Arkansas has started their systematic caseload reviews with the psychiatrist. We know that when we're talking to people about CoCM, I'll hear them over and over say, the systematic caseload review really is the secret sauce. And so making sure that you have a good team where the psychiatrist and the BHCM are working together, they're comfortable, they have a workflow. And I have to say, the BHCM has come into this never doing CoCM before, really excited. She has developed a template. So as she's doing her case presentation, she knows exactly what information do I want to make sure to include for the psychiatrist so he can get the absolute best information and make the best recommendations on that patient's case. And so they've started that. And we've met with the Woven doctors a couple of times since they have started, and they are reporting that it is really going well. They're very pleased with how the systematic caseload review has gone. And they actually, we zoomed them in to Arkansas yesterday, and we had a webinar where they talked about the role of the psychiatric consultant in CoCM, what it looks like, why it's important. And as I listened to them speak, and mind you, these are two new psychiatric graduates, excuse me, they're talking about the reason that they have chosen to go into CoCM is because of the access issues. And so, you know, they talked about looking and doing their residency. They noticed in some of the specialty areas, it was really hard for patients to get the access they needed. There's long wait times, and they didn't have access to these services. And so they're not the only ones, but as I talk to more and more psychiatrists about, well, what really interests you in CoCM, I'm hearing that more often. They're able to really spread their reach across a larger patient population and support those patients. So for me, that was really exciting to hear from them. We will have that recording. I think it's uploaded already to our website. And it was Dr. Jason Anawa and Dr. Cyril Piaget. And so if y'all missed that, please listen to them. They'll tell you themselves why they like CoCM and why they think CoCM is a needed model. And wanted to give another update. Eastern Arkansas is in the process of hiring their second BHCM. I think that Dawana scheduled 6 interviews yesterday afternoon. She was going to be busy finding a new BHCM, excuse me. And then we will be going on site to Eastern Arkansas February 27th. And the ABIN team will be traveling. We will be meeting the Woven doctors there, and we'll be doing a half-day training with Eastern Arkansas. And it'll be the first opportunity for their providers to meet the Woven doctors in person, and we're excited about that. We know Zoom is great, but sometimes if you could just sit down with someone and look at them across the table, it's a different experience. And so they're coming in. And then uh, we will be having our conference. Don't forget, I keep mentioning this, and Caitlin will talk a little bit about it, but um, we will be having the two woven doctors on a panel presentation, as well as doing a presentation on CoCM. So lots of CoCM events and activities happening. We're really excited. And so I feel like, we've talked a little bit about technical assistance, but with the work that I think we've been doing with getting this process, and when I say we, not just us, but UAMS has been working closely as well. They've had a couple of Blue and U grants, and they've brought together lots of different resources. So I think there's a technical assistance base that's already happening, and we're excited. Our hope, um, just so you all know, is we don't want to reinvent the wheel every time. So as we develop these resources and we see one of our sites really working well, we use those resources on the next site and the next site, and hopefully implementation will be easier and quicker. And so we're excited about all of those pieces. I'll pause there. I think that's a lot, and my apologies for my technical issues. I will turn it over to you, Tisha.
Hello, welcome everyone. Thank you for letting me give an update on what's going on at UAMS. It's been a busy couple of months. So we have successfully brought on our second psychiatric consultant. His name is Dr. Joseph Sokol. He is actually located in Texas, um, but is obviously licensed in Arkansas and works with us remotely. He is a very seasoned psychiatrist who's really excited and interested in education for our residents, and has already really done a lot of fun work with our residents to help teach them about prescribing and diagnosing and understanding psychiatric the role of psychiatric issues in health and well-being. So we're really excited to have him on board. We also have we have four behavioral health care managers hired, onboarded, and going, which has been a huge feat all in itself. So really excited. They are a fabulous team. They're brilliant and really engaging with patients, and the patients absolutely adore them. We are now officially kicked off and rolling in 5 clinics. So we are in Batesville, internal medicine here in Little Rock. We're in Helena, in Texarkana, and in Pine Bluff. And we have had multiple case reviews for all of those clinics. We have got those scheduled weekly. It's been really fun. We actually have some physicians who come and sit in on our case reviews. So not residents, but training directors and physicians who just want to hear and learn and be part of that process. So it's been really great. Trying to think about what else has been going on. It's so much. Does anybody have any questions based on kind of where we are implementation wise and kind of that piece?
I am curious, this is just for my own curiosity. How's the engagement going with your care managers? I know you guys have, like, it sounds like you got all four corners of the state almost, a presence there. And I know sometimes it's hard to, I know you said that they really like their care managers, but how's like the caseload going? Are they making like quality referrals? Are you still trying to figure out, what are our BHCMs for?
We're definitely still in the working phase. We did so. Carson, who is working with Texarkana, and Helena. I mean, we got her rolling early in In January, and she already has I think 15 on her caseload. So I feel like that's a pretty good.
Yep.
We're still kind of struggling in Pine Bluff, but we also did not have an in-person behavioral health consultant there until just a couple of weeks ago. So we've been that's been a transition clinic. We've been training another new person there. But I have no doubts that they will be very busy soon because Pine Bluff has a lot of needs.
Oh yeah.
Um, so, one of the things that we're really focusing on is, whenever you start any new program, really what rises to the top are the very severe high utilizers that people have not been able to get support for. And so that usually is the first round of patients that we get, which takes a lot of time and energy. So we spend more of our time trying to get them set up with good services that they need, rather than actually treating what's going on, because that's not what we're designed for. But we're definitely designed to support them. So we've had some patients from Texarkana where I've actually met with the patient virtually to try to get some diagnostic clarification, kind of like the borderline personality disorder versus bipolar disorder, and trying to kind of learn some motion regulation so we can help get her into, especially mental health setting, to really get her all the supports that she needs. But before we can get there, we've got to make sure that we know what we're trying to support her with. Um, so that's kind of how it starts out usually with us. But like in not Pine Bluff, Batesville, where we've been there for a while, we're now shifting to, okay, how do we systematically, or not how do we know, but how do we get everybody to systematically start referring people, based on scores and based on, it doesn't have to be an emergency. It can be just trying to support patients. So we're kind of rolling into the more moderate range in our clinics we've been in for a little bit. Does that help answer your
Yeah,
question, Caitlin?
absolutely. And I think it points out a really important fact. I mean, grew up in the PCBH model, so as a BHC, so it's a tiny bit different. But what I consistently hear is that, to build that rapport and to build that trust with your provider, they're going to probably throw the most high need patients at you. Like, I need help with this. I remember my first patient in my clinic was somebody that needed, like, to go to a SNF, like needed to be removed from the home and get services, which is a big deal and hard to do in primary care. So I think that is I'm glad you brought that up. It's such an important part of that rapport building. Is absolutely, I'm not treating these in primary care. This needs a higher level of care, but what I will do is support you and help you manage that. And I think that creates a very strong foundation or strong bridge between the provider and the BHCM, because it's all about that trust, and then that trust trickles down to our patients, right? So it's just something I keep hearing. It's one of these days we're gonna have to like run a paper on that. But I love that that you brought it up. It's like, yeah, you know what? That's fine. We're problem solvers. That's the job. So we will help you figure that out.
Yeah, yeah. It's a process. It's part of the implementation process, and also part of our learning of what do our clinics need, because our
Right.
goal is to meet the needs of our patients. And so the collaborative care model is wonderful and flexible and has lots of different ways that we can use the structure to
Mhm.
support a very wide range of patients. So I like it. I did forget to mention one development is that we are actively working on getting child psychiatry time right now. We do have a child psychiatrist at UAMS that has some time. So I actually had a meeting this morning about our budget and where we have space or where we can move things around to get his time, because our clinics, like Helena and Texarkana especially, and some Pine Bluff, and then as we roll out to Fort Smith and El Dorado, they do have a pretty high pediatric population. And we do have some pediatric clinics. So Rawling Road is a pediatric clinic. So we are going to need some pediatric time to support. But we're really looking at that person, instead of them really being like in the collaborative care be more of a resource to our psychiatrists. So,
Makes sense.
um, uh, Dr. Sokol and Dr. Tripathi are comfortable and want to support our doctors in any way, but at some point you've reached your expertise, especially as you get younger. So having a person that we can rely on to help support whenever, for diagnostic clarification and for supporting, kids, that's something that we really want to do. So that's another thing that we're working on. Had
That's
a meeting about that this morning too. So
that's
the
great.
last thing, go ahead. The
Go
last
ahead.
thing I wanted to do is, so as part of some of our reporting, I did some case study write-ups, and I thought it would be really fun to kind of share some examples of patients that we've worked with, just to kind of get a flair for what we do, and also like really how people get better. And these are not like, I mean, these are examples that are pretty. Uh, they're not just, oh, let me pick out some good ones. They're pretty common. So I was just going to share the two examples. They're really, there's many that we could. One, and I've changed names and changed things out around a little bit. So this is not PHI. It's more of a conglomerate, but it's very specific. I mean, it's patient examples, but I've changed some stuff so it's not, identifiable.
So do
So,
you want to share your screen? Because I know I've seen you had them on a slide. We could definitely do that.
yeah, I can. It's little words, so I'm not expecting people to read it. Eh,
Oh, no
I
worries.
can share my screen. Hold on. It. Can you guys see that?
Yeah.
It's like a piece of paper. Um, So the first patient, and these are both internal medicine patients, mostly because those are the ones I'm more familiar with, because I was actually doing the psychiatric consultation for a while before we got Dr. Sokol, but I'm working on other patients. So Katrina, a Black female in her 50s, presented to her primary care doctor for her wellness exam. She has obesity, high blood pressure, and diabetes, and her doctor noted that her PHQ-9 score was elevated. And she has a history of difficulty managing her high blood pressure and depression. The doctor got consent from Katrina and reached out to her behavioral care manager. She was finally got a hold of her 20 days later, and the care manager completed an initial assessment and helped Katrina set goals for her health and mood. Her baseline scores were a 16 on the PHQ-9 and a 17 on the GAD, which are moderate to severe scores. I think that people with those scores probably have kind of a moderate to severe levels of anxiety and depression. Her goals, and again, we work with them to set their own goals, were to stop smoking, improve her health and anxiety, and to cope with family stressors. So over 3 months, Katrina had 6 telephone calls with the behavioral health care manager and 3 case consultations, which happen weekly. They may not be talked about every week, with the psychiatric consultant, totaling 88 minutes of care, with an average of about 30 minutes per month. Katrina never physically saw the psychiatric consultant on physically or over video. Over the 3 months, her PHQ-9 scored changed from a 16 to a 2, and her G87 changed from a 17 to a 3. Both of those are in the mild, non-clinical range. She started on nicotine replacement, started taking her medication as prescribed, reported an improvement in mood and sleep. She met her goals of improved coping with stress and improved mood, and she did reduce her smoking and is continuing with this goal. Also, she was disenrolled after 3 months. So we're no longer currently working with her, but I checked into her chart, and her last PCP score, our last PCP appointment, her scores were still low, and she reported continuing to reduce smoking, with a goal to quit in February. I think I looked at her chart last month. Um, and this is an example. We get we track scores, so we look at every single time we talk to somebody, we get their scores, and so this is her scores over the time period that we were working with her. Um, so that's Katrina. It's an example of someone that probably we would not have been referred for behavioral health care and or wouldn't have gone and got 3 months of care, you know, 88 minutes of talking with somebody or about her, and she in 3 months went from severe to mild.
That's awesome.
And she's a really cool lady too. So, as someone who's got to know her um, through the care manager, I never talked to her. The other example I have is Matthew, a black male in his 20s, also presented to his primary care doctor with elevated levels of anxiety and depression and migraines, which were interfering with his ability to work. He had over 10 emergency room visits. It's actually 12, but I was trying to be less specific. Emergency room visits in the past 5 years for migraines. He had tried traditional therapy for his depression and anxiety, but did not like it because, and these are his quotes, they kept asking me the same questions. He agreed to engage in collaborative care to assist with his mood and coping with migraines. We got consent from the primary care doctor, and Matthew was contacted 5 days after his primary care doctor appointment. The care manager did the initial assessment and helped Matthew set goals. His PHQ-9 score at the beginning was a 22. Again, that's severe, and 17 for his anxiety levels. Again, that's severe. His goals were to improve his coping and management of migraine so he can work and improve his financial stability and regain employment. He was, at the time we started working with him, considering applying for disability because of the effect of his migraines. So over 4 months, Matthew had 6 telephone calls with the behavioral health care manager and 3 case consultations with the psychiatric consultant, with a total of 163 minutes of care, so about 40 minutes per month. He never saw the psychiatric consultant in person. Matthew went back to work. His PHQ-9 scores went from a 22 to a 2, and his GAD-7 scores went from a 17 to a 14. So from severe to mild and severe to moderate. He started working again after not working for about 2 years, and learned words to make sure he takes his medication on time, received assistance from the behavioral health care manager on ways to afford his medication. So that was one of the reasons why he wasn't taking his meds, and learned skills for managing his migraines and also his worry about his health. He's now working and reports his migraines are more in control. He's not had an emergency room visit for 6 months. So this is someone who had 12 emergency room visits in 5 years. And since we've started working with him, he has not had an emergency room visit. He was averaging 2 to 4 a year before he was enrolled in collaborative care. He's now on a relapse prevention plan, which means we're still working with him, but we're only working with him about once a month to check in and see how he's doing. And we will continue to disenroll if his progress continues. If I'm smart enough, I'll stop sharing.
These are awesome. I was just going to say, Tisha, I think that the examples really help bring to life what happens in CoCM, the progress that could be made, how quickly progress can be made, and seeing that discharge piece, right? So it's not sometimes what happens, there's extended periods of care, people drop out of care, we don't know why. But I think in this model, it's really nice to see improvement and evidence through the measures to show improvement. So
Yeah, yeah. And I think, it's just really important for payers. And, a lot of private payers are very, adamant about this model because it has been shown to reduce other types of medical and mental health use, both in emergency rooms for mental health issues, but also emergency rooms for medical issues. Our psychiatric consultants have really have caught things in the chart and brought to the attention of their PCPs for like labs that haven't been followed up on, or looked at things from a different perspective and asked for different labs. So it's not just, focusing on their mental health, but looking at them from a holistic standpoint. And our
Absolutely.
patients love our care managers, so they really enjoy engaging with them, and that makes them more engaged with our whole primary care team.
Awesome. Another cool thing that I heard you say is we have a pediatric psychiatrist with some extra time who might be able to do this, which is amazing, and an amazing resource that UAMS has. I think that one of the things and one of the reasons we're so excited about the woven docs is if you're not in a larger system, it can be challenging to access CoCM, psychiatric consultants. And how could you afford to have someone just short amounts of time? And so I just want to say, not that I'm advertising for the Woven Doctors, but they have gotten their Arkansas license, and we're going to have them working more and more with clinics in Arkansas. And so just knowing there's huge needs, right? As I hear you talk about, if we expand to the pediatric population, um, which we will as we see, this grow, how are we going to access those resources that we need in order to support the model? So um, that's important for us to be thinking about, talking about, especially as we start getting this program grown.
Thanks for sharing those cases. It's really good to for people to see how it really works and see some of the outcomes in real people.
I exited
You're
out
very
of
welcome.
the I exited out of the agenda, but next is just the events, and then we're done unless anybody else has updates or anything else we wanted to discuss. I don't want to cut anyone off. Nope, good. Okay. Well, then it's my turn. Not to sound egotistical. I've got a couple of things that are going on for not necessarily just COCM, but there's a couple of integrated health things going around the state over the next couple of weeks. Let me share my screen. Hopefully I'm on the right thing. Okay, so you've heard us talk about it. You're going to hear us talk about it until April is over. Is we're going to have our conference on April 8th. And we are gonna, I mean, this is geared towards COCM. This is gonna be a really good resource for even our really small clinics in the state that are just getting started or really just even considering it, coming and hearing about the possibilities, about financing it, about the different components that you need. Is going to be really at the heart of what we're talking about at this year's conference. So again, April 8th, we're actually over half full on our tickets. So if anyone has not registered, Misty, you might want to kind of correct me on that, but we're pretty close to running out of tickets and being at capacity. So just make sure your team has them. We have CEUs accredited for social work, counselor, nursing, medical CEUs, and I think pharmacy, right? Did we get that approved or no? Okay, we did, which I think that's pretty unique. We got several CEUs for pharmacists, and we would love for them to come out and hang out with us too. So make sure you push that resource out to them as well. Oh, Misty says we have 50 tickets left, so not to alarm anyone. That's not that many. So that's going to be at St. Vincent in Little Rock. I don't know how I get these. There we go. Okay. So that's one of the resources. Another one is just the webinar that they were talking about with Dr. Jason, Dr. Cyril. That is uploaded. You can either access it via our webinars page, or you can always go to our YouTube, which Jenny, our coworker, manages, and she does a phenomenal job with. That's already up there. You can see all our other webinars. I do want to plug one more thing here on our YouTube is we've got a podcast. We got 4 episodes that are up. We do have CEUs available for those episodes, but only until March. So and they're through UMS. So if you listen to the episode, just there's instructions in the description to email Mary Beth to make sure that you get your survey and to get your CEU certificate. But again, they're only good until March. So if all my licensed folks on here need some kind of a resource for some CEUs as you collect yours and renew your license, that is a good and easy CEU to get. You can pop that on while you're making dinner or you're driving. So that is available. There's a couple of different subjects. And then the last thing is office hours is supposed to be next week, but most of the avian team is going to be traveling or out of office. So we are not having office hours in February. Most of us are actually going to be at this conference in Fayetteville. U of A is putting on an integration conference. I think it's 2-day long. It's focused on PCBH. Some of these names I'm sure many of us will recognize as working in PCBH, but as we all do, we borrow things from different models to meet our patients where they're at. So I'm sure it's still very applicable to the CoCM discussion. This is a free conference. I'm really excited because I've seen BT and Bowman present, and I'm really excited to hear them again. But we will be in Fayetteville, so we will not have office hours for February. In March, we will, and I believe it's on the 21st. I'll have to look at my schedule again, but of course, I'll send out a reminder and a little picture with it that will remind you guys of office hours. And then the last thing, I don't have a picture of it because I can't find it, but there is a new BHCM office hours that I think Ames is putting on. Kim, am I right? Is it Ames that's doing that? Okay. And Monica, I think is running it. I cannot find the link for it, so that's something that we can get Misty to send out probably next week when we send out the notes for this. But there's a specific office hours just for BHCMs, and they're very adamant. Like they even say, like, if you're not acting as a BHCM, please don't stay on the call. I'm sure they'll probably be fine with us listening in once or twice, but that is a resource out there, and I think it's really unique. I don't think anyone else is really doing a specific BHCM office hours, and I think that's a great opportunity for us to create an even bigger cohort, a national cohort of our BHCMs, and be able to trade kind of secrets and intervention techniques and ideas across the states. So did I miss anything? Anything that I don't remember happening? Cool. Yeah. All right. Well, I'm done. Kim, I'm gonna hand it back over to you to finish this out.
Sure. No, awesome. Thank you, Caitlin. A lot's going on in the CoCM world. And so we appreciate you all being here. We appreciate all the updates, and we will see you in March. And maybe see you on some of these webinars. But if not, I hope to see you all in person at the conference. With that, have a wonderful weekend. Happy Valentine's Day, and we'll see you soon.
See you later. Good to see everybody.
Thank you.
Bye-bye.
Bye-bye.